Hello everybody, this is Dr. Medicine RX and in today's video we'll be discussing about cutaneous small vessel vasculitis. So this is also called as hypersensitivity vasculitis, hypersensitivity angiitis or cutaneous leukocytoclastic angiitis. So basically this is one of the most common cases that we see in our OPDs where we get a female who has presented to you with certain lesions on her legs, and when you go to examine you find that there are some non-blanching erythematous or purplish papules, and you make it out to be purpura, and the lesions are pretty asymptomatic, and the patient also does not usually give any history of preceding infection or any drug intake, and sometimes there can be a history of recurrency also. So these cases, they come under cutaneous small vessel vasculitis. So it is a small vessel vasculitis which primarily targets post capillary venules in the skin and presents as symmetric palpable purpura of lower limbs. So as the name suggests, it is a small vessel vasculitis affecting the vessels of the skin, and these present as symmetric palpable purpura, and most commonly they occur on the lower limbs. Coming to epidemiology, so cutaneous small vessel vasculitis is the most common type of vasculitis. All age groups are affected, but adults are most commonly affected, and both genders are affected, but there is a slight female preponderance. Coming to etiology, so in more than 40% of cases, the cause is idiopathic. You are unable to pinpoint a cause. In 20% of cases, a preceding upper respiratory tract infection might be present, and most commonly caused by beta hemolytic streptococci. And other infections such as viral hepatitis, HIV can also be present. And in 10% of cases, drugs, especially antibiotics, of which beta-lactams are the most common cause, and other categories of drugs such as NSAIDs and diuretics can also be responsible. Coming to pathogenesis, so it's a type 3 hypersensitivity reaction. So there's going to be immune complex deposition in the post capillary venules. This immune complex, it is formed by foreign antigen and also along with an antibody which can be of IgG, IgA or IgM class. And following this immune complex deposition, there is going to be activation of the complement cascade, which leads to production of C3a and C5a complement proteins. And these proteins, they cause endothelial damage. They recruit further neutrophils, basophils and mast cells to further produce inflammatory response. And along with that, C5a also upregulates adhesion molecules on endothelial cells and leukocytes. This leads to attractment of further more inflammatory cells, leading to increased recruitment and further more inflammation. Coming to clinical features, so the first foremost clinical feature is going to be palpable purpura, which is red or purplish in color of 2 to 5 mm size, and the patient is asymptomatic, but in certain cases there can be itching, burning and pain, and they occur more on the dependent sites of the lower limbs. They also can occur on sites of trauma and friction, that is they can exhibit a Kobner's phenomenon, and we have to ask for any associated fever, arthralgia, arthritis and myalgia, because in that case it rules to systemic involvement as well, and most likely it might not be a case of cutaneous small vessel vasculitis and something else. Other clinical variants of the disease, they include urticaria-like lesions, targetoid lesions, vesicles and bullae if the inflammatory response is high, and erosions and ulcerations in long-standing cases which leave a central hemorrhagic SR. Coming to complications, ulceration of skin, post-inflammatory hyperpigmentation and end organ dysfunction in rare cases. Coming to diagnosis, the American College of Rheumatologists, they give a criteria of five complaints, and presence of more than 3 or more criteria points towards the presence of cutaneous small vessel vasculitis, of which age at onset should be more than 16 years. Medication history should be present at the age of onset, that may be a precipitating factor. Presence of palpable purpura, presence of maculopapular rash, and biopsy with histological changes of leukocytoclasia. Coming to investigations, first and foremost is going to be histopathological examination of the skin biopsy specimen, and they should be taken from center of a fresh lesion, preferably 24 to 48 hour old fresh lesion. And on histopathological examination, we find a neutrophilic infiltrate in post-capillary venules and also in perivascular zones. There is going to be leukocytoclasia, that is leukocyte degeneration, which occurs by karyorrhexis. Karyorrhexis is nothing but nuclear fragmentation which presents as nuclear dust, and the chromatin in this nucleus, it is distributed irregularly throughout the cytoplasm. and there can be fibrinoid necrosis within blood vessels with edema and RBC extravasation. In many of the vasculitis, these are most common type of features present on histopathology. That is, there is going to be leukocytoclasia along with the fibrinoid necrosis and a neutrophilic perivascular infiltrate. In drug-induced cutaneous small vessel vasculitis, instead of neutrophils, there can be higher number of eosinophils. On direct immunofluorescence, IgG, IgA, IgM, C3 and with or without fibrinogen can be detected in small dermal vessels. And to rule out other differential diagnosis, it is necessary to do furthermore tests in non-resolving cases or refractory cases that include anti-nuclear antibody tests, rheumatoid factor, anti-streptolysin O titer, quantiferon assay or MON2 test for TB, serology for HBV and HCV infections, cryoglobulin levels, HIV test, urine toxicology screen, serum protein electrophoresis and blood culture. Coming to management, treating the underlying disorder if detected should be done and it forms the mainstay of treatment. Antihistaminics are useful in itchy lesions or urticaria like lesions, and NSAIDs can also be helpful in certain cases. Systemic corticosteroids, oral prednisolone in dosage of 0.5 to 1 mg per kg tapered over 6 to 10 weeks if bullion ulcers are present. However, in most of our clinical approach, we tend to give systemic corticosteroids when the patient first presents. Colchicine about 0.6 mg BD or TID depending upon the patient's tolerance, GI tolerance. We can give it for recurrent, persistent and severe disease. It reduces neutrophilic infiltration. Dapsone in a dosage of 50 mg per day starting, followed by increasing it by 50 mg per day at weekly intervals to get a final dose of 150 to 200 mg per day can be done in severe disease cases, and it also has action on neutrophilic chemotaxis and it reduces the duration of the disease. Before starting dapsone, we have to check G6PD levels, baseline complete blood count and LFTs, and they should be regularly monitored as well once in every 4 weeks. Other management strategies include giving rituximab, hydroxychloroquine, azathioprine, and intravenous immunoglobulins. Some of the differential diagnoses are Rocky Mountain spotted fever, meningococcemia, arthropod bites, parvovirus B19 infections, pigmented purpuric dermatosis, drug exanthems, ITP, and polyarthritis nodosa. Thank you. Subscribe for more.